Cyber, it seems to be like next level when you're talking about people's lives. And things that we used to think are sort of more esoteric, like AI helping patients do stuff, isn't really a science project. It's actually the reality these folks are dealing with day to day. So I'm gonna ask each of them to do a really quick introduction of themselves. We won't spend a lot of time on that. And then we talked about a few things like really important ideas and topics that relate to the topic that we listed out. I'll restate it here in a minute. After I let each of the panelists introduce themselves just very briefly. They're gonna give you kind of a little bit about them, a little bit about their current role, and maybe one sentence about what they want to get out of the conversation tonight. Kathy, I'll start with you then.
Before we do that, let me just get Manhattan back on the line.
Oh, I'm sorry, they're not?
Just let me make sure. Are they back on yet?
I've done no
Just
confirmation.
before we do that, that's why I just want to make sure we get them on. Sorry for the delay.
Yeah, but if you'll just bear with us one moment. There has been an unannounced, or previously unknown, fire drill. We don't have to leave the building, but if you give us a minute, I'm hoping they'll sound the alarm.
So, funny story. So I got this pin from Secret Service agent, right? It's a Secret Service pin. And she was supposed to speak at one of the conferences. And she said, "Oh, I'm sorry, I couldn't get on the phone. I had a fire drill." And I'm like, what was it? Right? Because I don't know about you guys. If we have a fire drill at work, it's like because your boss asked you to get something of like, tell me how many 60-watt light bulbs are in the entire building or something equally as important as that. So I'm like, oh, I'm sure you probably can't tell me, right? It's whatever you're working on. What was it? She's like, what do you mean? Like, fire drill, alarm, went off. Like, you did it in school, right? I'm like, oh. So I always think of, when someone says we had a fire drill, I never think of, like, what that is. I don't know about you guys. So when will we know if they're back on? What?
He's checking.
You can go.
Okay.
Thank you. Thank you, everybody, for your patience.
It's gonna do that every time you turn it on or off.
All right,
before
that
you try
does,
it.
okay,
So
just,
don't be
you can
surprised.
hear me though, right?
Yes.
Okay, hi, everybody, I am Kathy Hughes, I am the Chief Information Security Officer at Northwell Health, which should be a very familiar name to everybody. We are now 28 hospitals, we just acquired 7 hospitals earlier this year, and over 1,200 practices. I've been the CISO for over 10 years, and I'm retiring at the end of the year. So this is my last shindig doing this. I'm really happy to be here. Thank you.
Thank you for being here.
Me? I'm Andy Hoffman. I'm a CISO for Stony Brook Medicine, only 4 hospitals, but over 200 practices. I've been there since November of 2019. Talk about being thrown into the fire with COVID.
And what would you like to, what is the most important thing you want to get across tonight? One sentence, go.
Try yours first?
No, you go.
Just one sentence.
Yes, you.
Just general data security and trying to, how do we mitigate the enormous risks that come up every single day?
I'd like to just add to that because I like to answer that question. I used to work for Estee Lauder, again, another household name. And when you work for a cosmetics company, it's about people putting makeup on and all that. Very different than working in an organization where patient life is at stake, patient safety, clinical care is at stake. And it's a really very important and very, has a lot of, just have to focus a lot of time and effort to make sure you understand that what's at the other end isn't a mascara, it is a person's life.
Although mascara is important too. Keith.
Sure. Good evening, everyone. Keith Dunling, Chief Information Security Officer at Catholic Health. So, not as large as Northwell, but certainly a name that's known to many, I'm sure. Prior to this, I joined the organization earlier this year. Prior to this, I was Senior Director of Cyber at the Cleveland Clinic in Cleveland, Ohio. So, spent a number of years there. And happy to be here, happy to be on the panel. And what I'm looking to get out of it, I think collaboration, especially in this era of division and difficulties, is something that I would like to see the cyber community show more of and do more of, because we're also here to help each other.
Fair enough. That microphone seems like you probably have to always have it aimed right at you and a little bit closer. It's not you, it's that microphone. Dr. Jason Lazar.
I'm Jason Lazar. I am not a CISO.
I am your token healthcare provider. I'm a cardiologist by trade. My first job was at Winthrop, where I was 8 years. And I now work clinically half-time at SUNY downstate in Brooklyn. Half-time means I put in probably more than a 40-hour week. The other half of the time, I have the honor of serving as the executive vice dean of the College of Medicine. So I oversee an institution of 600 faculty, 840 medical students, and 1,000 residents, and help the dean along with trying to make all that work in an underserved area.
Outstanding. So how many people there?
Lots.
The Pope was one time asked how many people work at the Vatican, and he said, about half. Andy, I wanted to start with you. So, first let me just sort of restate a little bit things that we wanted to talk about. Balancing innovation with interoperability and clinical integrity. That's why we've got Jason holding up the fort there. Key healthcare and cyber risks, trends that are kind of special to healthcare but apply to lots of different industries. AI and ML, of course, because like we're required. And how that relates to privacy, process, people. Cyber insurance, always a fun topic. Muting is love. Muting is love. That's not even English. I think we were hacked. Cyber insurance and how that relates to many different things, including medical device security, which I think there's a lot of fun movie plot that could be scary. And then finally has the very interesting that our professionals are mostly all hospitals because the New York State Department of Health standard is sort of really forward-thinking, especially as an update from HIPAA, and we'll talk about that at the end a little bit. Make sense? Cool. So I wanted to jump in. I wanted to start with you, Andy. Cyber insurance, just picking out of the middle of the pack, and medical device security. I think it's like a great movie plot when the pacemaker control system is on the same system as the Diet Coke machine, and lots of fun things could happen. But your cyber insurance companies are talking about microsegmentation and pushing you to do some of those things, and you're pushing yourself to do those things in a highly regulated environment. Go.
So for us, I mean, working for the state does bring some challenges and limitations with us. More often than not, we do struggle like every other organization in trying.
Sorry, in order for them to, you have to be like a robot. The microphone has to be exactly in front of your, because I can hear it cutting out on this side, sorry.
Is that better?
Yeah, there you go.
Oh, okay.
Yeah, there we go.
You're already loud, but just for the New York guys, they wouldn't hear you otherwise.
No problem. So, working for the state, being a senior hospital, does come up with some challenges. I mean, with cyber insurance, we are kind of regulated by the state. They give us what we need to do. We have to work on their templates on their business associate agreements. And when you have thousands of vendors that you're trying to regulate because they're either monitoring, doing services for you, whether it's SaaS or hardware, for us, it's a great challenge to do. So trying to get our third-party vendor, this microphone is rough. So making sure that our third-party vendors have the adequate cyber insurance, and that we internally are creating our control environments so that we can, like I said, our cyber insurance carriers are requiring more and more of us every single year. So we're pushing ourselves, we try to keep ourselves on that leading edge and a little bit ahead of them, at least to see what's coming on so we can get the controls in place before they ask. But for us, we've been really concentrating on our vendors because most of the breaches actually do come from either a vendor breach, as we've got a lot of other places. We got hit that Blackboard breach in 2020. They looked perfect from the outside. From an audit perspective, had every certification you could possibly want, whether it's NIST, ISO, PCI, and then a backdoor took it down. So for us now, we've really stressed the third-party vendor service and looking at their security controls in line with our own.
Kathy, you've got a few vendors.
Yeah, I think we have over 15,000 vendors,
Nice.
and that's probably a conservative number, and that's all vendors. I'm not just saying that's just vendors that we look at, but we have to pick and choose. You have to take a risk-based approach to what you look at and what your criteria is. Cyber insurance is increasingly difficult to get. When I first started many years ago, I think we had like 20, 30 questions. I'm looking at Michelle because she's the one that helps me coordinate a lot of this, and we have about 1,200 questions now that we have to answer in order to have, or hopefully have, a carrier, an underwriter want to insure us. And it's getting more and more difficult to hold our third-party vendors to certain minimums that we'd like them to commit to in contract. So that's been a challenge going, you know.
So talk a little bit about that. In a SaaS world, that becomes a little bit more complicated.
Yes, so in a SaaS world, well, typically you'd like a dollar amount, 10, 20, 30, $40 million, you know, if there's an incident that they would commit to. But now, since we're moving towards the SaaS model, a lot of the vendors are only committing to a certain number of times fees paid for in a year. So if you pay I'm making this up, $1,000 per year for a particular SaaS service, they might only be willing to cover you for 2 times those fees paid in a given year. So third-party vendors and SaaS providers are really minimizing what they're willing to cover you for, which is a challenge, especially given today's day and age. And then the deductible, as I call it, of what your cyber insurance require you to pay first out of pocket is increasing, right? So it's a very challenging environment.
To finish that thought, do you have any advice for people in that? So everybody's faced with that same challenge, right? My SaaS vendor only wants X.
Yep.
I need to cover way bigger than X. Any advice?
You gotta have good lawyers, but you also have to make sure that these commitments are negotiated up front as part of the contracting agreement and not an afterthought. I think that's really important. And then also make sure you do some kind of continuous monitoring to making sure that they're complying with your security standards as well as the regulations that you have to comply with.
Yeah, Keith, you're thoughtful on this sort of topic. What advice would you add to Kathy's?
I think I agree with pretty much everything. I think you have to have a strong relationship with your lawyers and supply chain.
Is this actually required?
Yeah, for New York it is. So keep talking, I'm gonna fix it.
Yeah, so I think that one of the things that's important about what you said is that you have to treat it as a risk approach and integrate it with your entire program so that, you know, really it's not an afterthought.
I'm actually so
Here, go ahead, turn that off. We're gonna go low tech, Keith. This one's wired and
Yeah.
plugged in. Old
Okay.
school.
Hopefully that works better. Starting over, I think you essentially have to take a vendor program and you have to integrate it with the entirety of your cyber program. You have to look holistically at the entire thing, and essentially how mature you're going to make your program is essentially how mature you have to try and understand their level of maturity as well, and the risk that they have with your data, with your services and whatnot. And I think it's also important, not just working with legal, but also working with the clinical staff to understand if this thing falls over in the night. There's what cyber's gonna do, what IT's gonna do, but what's the impact to the clinician and how you continue operations? And that's an important thing when you talk about indemnifications, super caps, things of that nature, so you can really negotiate hard on the things that have to be negotiated on and give a little bit on those things where it's, there's room to give, so.
On clinician, Jason, that's all you. Tell us, picking up from Keith's point, how do you view that in terms of the tech that they're giving you, what you're giving your staffers, and how do you think about that in terms of, things that could fall over in the middle of the night and what my clinicians need?
So I'm hearing that many systems have numerous vendors, but I would actually be cognizant of the fact that data flow has evolved tremendously. You used to go to the doctor would do some tests, and there was a flow of information from the physician to the patient. That's changed. Patients generate vast amounts of data. They do it through remote monitoring, they do it through Oura rings, they do it through a variety of means, step counters. They whip out their cell phones and access their labs from another system and say, look at my portal. So I guess the movie Everything, Everywhere, All at Once comes in because it's this confluence of data that then hits the practitioner, the provider, and then we're left to try to coordinate it, integrate it into an electronic medical record, which maybe that startup is compatible with, but often is not. So I would just remind the group that a lot of data is patient-generated and not well controlled by our data experts.
Fair enough. Andy, continuous monitoring, how do you do it? You have to take Kathy's. You and Kathy are a team, and Keith and Jason are a team now on the microphones, okay? Remember who your buddy is.
Thanks.
All right.
So yes, I mean, continuous monitoring, the program that we've been actually continuing to mature. So we use a tool called UpGuard, which is similar to BitSight and Security Scorecard. It allows us to monitor the vendors and their fourth-party vendors and breaches and identity breaches. So we get notifications where it allows us to automatically notify any of our associates that were affected, whether we can see if it was passwords or emails, and take a look at the vendors. If we see a sharp drop in a vendor, we'll get notifications and we reach out to the vendor to find out what happened, if there are specific controls that were either breached or they're not quite adequate. So it allows us to communicate back and forth with the vendors almost in real time when we see these incidents happen, to find out what happened and how are they going to fix it so that it doesn't affect Stony Brook.
Yeah, Kathy, you mentioned third parties. There's a certain very large database and systems vendor that was breached not long ago.
Yeah.
A lot of systems connected to that. So advice for the audience on that, or sort of experiential.
Yeah, so vendors get breached every single day. We read about them, we hear about them. It's very impactful when it affects a hospital and hospital operations, as you can imagine. And I was just recalling an incident where just a few weeks ago we were notified by a very large company that many millions of our patient records were potentially involved with a breach. And when we did the analysis, we found out, well, it was just demographic data. It wasn't anything related to any patient information or EMR, anything specific that identified a patient or their care. So it was very innocuous. And so we were able to get to a point where we said, okay, there was a breach that occurred. The vendor notified us according to contractual obligations and all of that. We did our data analysis, and thankfully, it's not a significant breach or one that's reportable under the HIPAA regulation or any other regulations. But these happen every single day.
Yeah.
A couple happen today. So we're constantly involved in all of these, and there's really it's going to probably continue into the future, unfortunately.
Yeah. Kathy, let me ask you one more thing, and then Keith, I'll bridge to you on the same topic. So we all have the issue of shadow IT. Business users, SaaS applications, they don't need much more than an API or just an auth to plug in. How do you address that? Advice for the audience. What are you doing in your neck of the woods?
What do you mean again?
So shadow IT, so
Yeah,
basically
shadow IT.
business users plugging in stuff into your network.
Right. So that's in healthcare, you don't want to necessarily cut off access to anybody, because there could be a surgeon that comes in the middle of the night to do some type of life-saving emergency surgery or some type of care that's absolutely needed, and they might need to plug in a device. So you have to constantly just make sure that you have defense in depth layers and that you're constantly monitoring activity that's occurring on your network, and if there is any type of anomalous or something unusual that occurs, that you can respond effectively. So we have a very solid, and I'm looking at Joe over here, medical device security program where we do have a tool in place that we can track all different types of medical devices and ascertain the risk on each, and then that helps us come up with prioritized remediation tasks, which include things like segmentation or disabling services ports, just to mitigate risks, because you can mitigate risks, you can never eliminate them.
Yeah. And Keith, how are you giving your clinicians and staffers what they need while sort of limiting the tools you don't know about that are plugged in SaaS?
So I think we're employing a lot of the same techniques to provide that visibility across our infrastructure, to see what's out there, to get in front of it, to secure it. We're trying to develop strong relationships with the business to support innovation so that ideally they don't have to bring in these tools without IT and cybersecurity being involved. You know, we're partners with them. And I think that's one of the things that cyber probably has to continue to improve is we have to understand that healthcare is also a business. It is, you know, there's innovation, there's invention, there's research. We have to move IT in healthcare at the speed of what the patients and the clinicians need us to move. Because that's generally why shadow IT exists, is because IT has gone too slow to adopt something, or we'll get back to you in 2 years. Well, the need for that is, you know, I need that in 3 months, not 2 years. So I think that's one of the things, we've got to address it from technology, but we also have to be better partners from a business standpoint.
Yeah, perfect. And by the way, you guys, please, like, use the app if you can, but if you have a question like that stays on topic, please, by all means, like, don't check your phone or be bored. You're a people guy, people process technology. We just talked about data and clinicians and patient data, where patient safety comes first-ish. What's your point of view to protect the hospital and the patient?
Again, it's you're trying to thread the needle, and while I completely agree with what Keith was saying, that we do need to evolve. We also need like I said, it has to be a partnership. Clinicians also and the business side have to understand the security controls and regulations, what we need to put in place, because our job in general is to secure the data and the organization while not putting patients at risk. Unlike clinicians, where the patient is that's what they're focused on, our job is risk analysis. I always say it's a service delivery, which is patients and processes, versus a risk mentality. It's professional skepticism, and I know you're gonna laugh, but I tell when I present, I said, my job is not to think about the client. We think about the client as an organization, but my job is to think like a crook. What can I steal? What can I exploit? How do I get it? And what can I break? Where can I do with it? So my job is to look at these things with a very different viewpoint than others, but to Keith's very relevant point, we need to balance that with the needs of the clinician and the business. So partnering with them so that they understand the why we're doing what we're doing is by far one of the biggest arrows in our quiver. If they understand it and we train them, they get involved in it. They take ownership of these things, putting the risk not just on us, but a shared risk analysis.
Yeah. So Jason, you talked about the sort of most prevalent patient data portal, which is my phone. How are you kind of at the front line working with that and the systems within the environment? What's your point of view?
I wish there was better integration between portal data.
Integration at the clinician is clearly not the answer. I get it. Yes.
It clearly is not. And look, I understand the chief role of the CISO. On the other hand, the CISO is sometimes a patient. So you have schizoid ways of thinking, protecting the organization, protecting the records. On the other hand, integration is key. As I said, these data come from everywhere, and it's very hard to integrate them and make the best clinical decisions and the best prognostic predictions when you don't have it all there right in front of you. And we're working in real time, and we're working under time constraints as well.
So luckily, Kathy, none of our doctors are taking our stuff and slapping it into ChatGPT to get an answer, are they? That doesn't happen, right?
Oh, no. No, what we've done at Northwell is we have our own AI hub. So we have our own versions, proprietary, different engines, LLMs that we allow clinicians to use, where they can copy and ask all kinds of questions to get clinical diagnoses or recommendations, prognosis, all of that. So that's been our approach, and we've cut off access to the public sites. Now there's new ones cropping up every day, so we can't prevent everything, but we strongly encourage, we default everybody that goes to a ChatGPT type site to go to our internal AI hub and artificial intelligence hub and to use the various LLMs that we have available for them to use. So that's one of the ways that we're making the AI technology available to clinicians specifically, as well as everybody else, to improve business operations and how people do their work. So it's been we've had a very positive result from that.
Don't shut it off. Andy, governance infrastructure in your neck of the woods, around AI specifically.
Very similar to what Kathy was talking about, is that for AI, listen, AI is not new, right? It's the explosion of recent, particularly applications in LLMs and engines like ChatGPT. It's an application like everything else with its own unique risks and coding, but you govern it very similar to, Kathy and I have talked, we're both ITIL people, so when we're looking at these things, it's software development. So managing how they're done, managing the risk around it, and putting a solid governance around this. So as they're coming in, we're not going to get the ready, fire, aim, approach that they liked it, they bought it, and now we got to try and figure out the risks and controls associated with it, and trying to integrate it within our, our infrastructure.
Yeah.
So for us, governance, looking at before it comes in, as kind of Keith was talking about, getting involved in the process prior to purchase, prior to integration, assessing the risks with whether a questionnaire, talks, working with
Kathy's
vendors.
1,200 questionnaire.
Yeah, no, we've actually, the risk, the NIST risk AI RMF is actually very good. It has questionnaires that you can pretty much boil down. I think we have it down to like 25 or 30 questions to talk about the major risk areas. But it's getting that information from the vendor and getting into a governance committee so that we can assess the risks and not yes or no. It's here's what we believe the risks are, and now you need to provide your input.
Keith, what does your hospital do with regard to sort of AI things that touch patient data?
So we have a very similar assessment process with a questionnaire. We're developing some questionnaires that are very AI specific as well, so we can kind of break that out and really double click on those things. And obviously we're upskilling our people to work with developers, work with our partners to help us understand what those risks are. So we're not really trying to be the Department of No, if you will, when it comes to AI. We're trying to be the yes, but with these contingencies or recommendations. The other thing we're trying to do is really use AI ourselves so that when we give feedback, it's because we're coming from a place of cyber practitioners, but also people who want to solve problems with AI themselves. And we found that that's been helpful when we have these discussions with people. We can understand what they're trying to do because sometimes we're trying to do the same things ourselves.
Yeah.
And I think that helps to kind of humanize the process so they don't have to come begging for an approval from someone who doesn't really even understand the thing that they're approving or declining. So
yeah,
that's kind of been our tactic.
Jason, you told me about AI transcription being a big help to clinicians, didn't you? Or was it Andy that you said that?
I think it was Andy who mentioned it, but I certainly concur with that. Saves a lot of time.
So as a clinician, what kind of things do you see on the come that you want to put in the hands of doctors, like while they're in front of patients or when they're reviewing notes or for further recommendations, et cetera?
I think most physicians use AI scribeware very differently. Most will record a conversation with the patient's permission, push a button, and all the irrelevant stuff sort of goes out the window, and it kind of self-organizes it into the various parts of the electronic health record. And then there's decision support. But I must say, for all of the decision support solutions, most physicians like to keep that internal. That's their job, that's their role. We don't find it helps all that much. And most forgo, at least in my institution, in my perspective, when I was responsible for starting our Department of Family Medicine on AI scribeware, most don't use decision support. Simply saving time through electronic scribes.
Sometimes it's scary if you're in a doctor's office and he's reciting things you don't know. I kind of think when they get back to the office, they're like, oh, this guy's a goner. Forget it, don't spend any more money. Note to insurance company, save your bill. Kathy, you have a number of processes in place because of the size of your hospital. What kind of processes have you put in place around AI as it relates to patient care?
Yeah, so we have a number of different committees, and one of the more recent ones that we've implemented or initiated is an AI risk governance and privacy committee, which is we have participants at senior levels of the organization from clinical and non-clinical areas, our compliance area, all the major areas, and they all we go through a formal process where every application that we're considering bringing into the organization, we do an assessment, we do an evaluation, and we come back with conclusions in about 10 different categories if the risk is either low, medium, or high. So as mentioned before, we don't say yes or no, we say here's the risks, and just so that you're aware, and you make the business then, the health system makes a decision based on weighing both the value that a solution will provide along with the risk.
That's so important. Now, you talked about routing, so general AI requests go through your LLM. What about in the cases, and this question comes in from one of our users, what about in the case where it then has agents that want to reach out to other bits of data within the patient record or within the hospital? Are you addressing that through this?
Yeah, I think that's being addressed by more applications that have AI integration capabilities. I know that it's been mentioned that there's a lot of work to be done
Sure.
in that area. So I think that's an evolving area. Really what we have available is your simple conversational, I know personally I've had test results that have come back and I don't know what any of this means. So let me put it into AI knowing that it's secure and just having it say, can you interpret this in English for me? It's very helpful to do that. So I think there's some benefits that clinicians can derive from it, and I think the drive is to go towards more integration with EMR systems. I know Epic, which we're about to go live on in 10 days, has a lot of AI capabilities.
You got a lot of busy things there right before you leave
a
here.
lot. Bought 7 hospitals, we put a new EMR system in, so there's a lot going on. But a lot of the applications have this integrated capability, and our main EMR will have even more with more future new capabilities built in.
So, Andy, so your first reaction might be sort of like block that stuff. You can't do that. So how are you adapting this sort of yay or nay versus risk-based approach in your hospital?
We're definitely taking a risk-based approach. Again, as both the other CISOs on, they said, we're not in the no business. It's, I like the yes and, kind of improv, but yeah, it's one of those things we have to look at the AI. As long as we're involved prior to they try and integrate this thing, where we can properly assess the risks, get the answers that we can provide to the senior management, the executives, because that's where the risk really needs to be decided. Whether do they want it, does it fit with our tolerance or not? We're not in the no business. The problem is that, again, the ready, fire, aim, sometimes they buy things, we find out after the fact, and now we're trying to mitigate it, either isolating it, putting additional controls in place, even just simple education on simple things like ChatGPT, right? Before we have Copilot, we're Microsoft Teams, so we're using Copilot to do our AIs.
This whole thing is being recorded by Teams, so Teams just said, we are pleased to hear it, the board responds.
But for us, it's making sure that the users are educated, not, if they're gonna use Copilot, use our Copilot, use our AI engine, as opposed to just going out and putting their, if the resident copies his medical notes in ChatGPT because he wants them scribed. Okay, well, if we educate them, they're not doing that and providing, again, you guys have the AI portal, we're providing it to the users that use Teams to do this, and you can educate them to do so. Again, getting them on our side. If they understand the why we're doing what we're doing, Northwell's got a very large, we're still trying to manage, small groups are trying to manage huge populations of users. So the best thing we can do is educate them on the why and get them to do the work.
Got to be so much fun to have the majority of your users with 10 years of college under their belt. Keith, you started saying this sort of how the AI could help us be less about no. Can you expand on that a little bit?
Sure. I mean, I think, when it comes to adopting things like AI, we're going to continue to see it. It's going to become prolific throughout all of our applications. It's, just like virtualization and all those other things that have come along, not necessarily, IPv6, which apparently is like taking 20 years to get rolled out. I think it's not going anywhere because it's been here for quite some time. It's just now been commercialized, and patients have easy access to a simplified interface, and patients have an expectation that we're using AI to enhance and augment and support our incredibly skilled nurses and doctors. But they're asking, well, I want to make sure that you have this and you're using it to the full advantage, because they're using it as well and they're impressed with it. So I think bringing it full circle, this is how we really have to look at innovating our way to a better tomorrow from a healthcare standpoint. And that requires us to say less no, more yes. Bring these things into the organization, and really, this is our opportunity, I think, to emerge from kind of the back areas of the business and really partner to change healthcare, because it's not going to get any better from legislators. There's not going to be more funding. It's a tough job that I don't think is going to get any easier, but let's use the technology to make the outcomes better, the experience working with patients, and the patient experience better. So I think that's how we can change the mantra from no to yes.
So Jason, it seems like the most underused security control is empathy. Talk about sort of the human factor in terms of, are we relying too much on this data? Like, how do I sort of give my clinicians what they need but not have them over rely on it?
Yeah, I think you raise a good point about balance, and not only the humanistic side, and AI won't do that. This thing is great. It'll tell me how much deep sleep I have, but
he has an aura ring. That's this thing
as I mentioned,
pointing to.
But it will not be there as a source of empathy, compassion, connection, communication. All the things that I think many physicians went into medicine for. I'll also mention that, for me to go from my clinical office on the second floor of the hospital, and in many hospitals, cardiology is on the second floor. So if you ever feel like you're having a cardiac event, you want to wind up on the second floor. Yeah, the second floor. If when in doubt, go for the second floor if it's serious. But
we're in the IT, they're in the basement. Well, where they clean the uniforms, right next to that.
Well, that was my point. And that is, if you go, maybe 500 yards, down a few flights, cross over, maybe upstairs, then, do a U-turn, then go down to the basement again, you'll get the IT folks. And I don't say that disparagingly, but it's not practical for your IT setup to be in the middle of a clinical area. And I actually feel that geographic separation is really an obstacle for IT folks to understand the clinical perspective, but also for the clinical folks to really appreciate the need to protect, the enterprise. And, I hope presence is a powerful statement, because that's why I'm here today, amongst a number of CISOs, because it's that collaborative effort which I think is crucial, and I think my colleagues up here on the stage have really spoken to that very nicely.
So do you have any advice, this comes in from our audience thinking, do you have any advice for people that would want to try and get all of that data into their patient records? So I've got my phone, I've got my Aura ring, I've got whatever. Any advice for patients that you think, or you think there's an appetite for the hospitals to address that?
I think you have to work with the office up front, understand what their capabilities are, what their system are. To be honest, I have some patients bringing me written blood pressure logs, and we alpha scan them into the darn system, because there's just no other way to put them. So I don't think there's one size fits all, and I think you have to approach this individually with wherever you get your medical care.
Yeah. So Kathy, and this is sort of, we haven't really talked about it. Is there an appetite to provide guidance to patients with regard to sort of bringing BYO data?
Yeah, I would encourage it. I mean, the more data a physician can have, I think the better able the physician will be able to help them. Yeah. And I think there's a lot of work that has to get done in this area, but I know my sister's a physician, so, you know, I make sure when she's my primary care physician, that she knows every surgery, I monitor different things to make sure I'm within, you know, within normal ranges of whatever that we're monitoring. And I think it's important for everybody to do that, and it should be encouraged. And I feel for physicians, because they don't have access. They have access to their hospital, their practice's records, and maybe if that hospital practice has decided to share with other health systems, that information will be shared. But there is no global standard for that, and I think there should be, and I think there should be ways that patients can decide whether that data should be part of their permanent electronic health medical record or not. And I hope that we continue in that direction.
So that you just don't have to buy all those
Right.
hospitals. 7 more was enough. Andy, we talked about AI. You look like a tabletop guy. Have you thought about AI scenarios in your incident response plans?
Yeah, a bit. I mean, we're a startup shop, so they're rolling out their AI engines as well, more and more each day. We're just in the infancy of it. You know, as we do our tabletop exercises, AI is now part of it, but I haven't rolled out a specific AI tabletop scenario yet.
Okay, Keith, are you doing anything from an IR point of view with regard to AI?
So we're developing a cyber-specific AI engine that will assist us from an incident response standpoint, generate tabletop scenarios, and really help us, you know, augment all of our operations from a cyber standpoint. One of the things you bring up tabletop, I wonder how many of us are thinking about AI as the subject of the tabletop, where it becomes the attack surface that, you know, we have to research and explore. Just something that, you know, of interest to me is, as it becomes more and more critical, it's going to become more and more directly attacked. So just some thoughts on that.
That's fair. So Andy, let me stay with you for 1 second. Are there public AI models that connect with any of your systems? And if so, how are you managing the DLP around that?
We're trying not to, actually.
Okay.
So any of our AI models, whenever we contract with a SaaS vendor that is going to provide us an application, they can't use our data to do any learning. That's in our contract. That's part of the SUNY template. So no, anything that we're doing is doing internal. Again, educating our developers in that fashion. But no, we try not to use public databases like this.
Did anybody hear the Zscaler CEO bragging that his system is trained on 500,000 endpoints every day? Like, kind of admitting that every endpoint is feeding there. Like, that was awesome. Kathy, you were nodding your head with regard to sort of controls around DLP and data and how data leakage and so forth. How are you addressing it?
Yeah, so same thing. Contractually, we don't allow it because we want to make sure that data can be shared within the environment. You know, that's very important, and that's why we have the internal AI portal that's available where it learns internally but doesn't share externally. And if we do have SaaS providers, we do specifically state in contracts that they can't use our data without our authorization to make sure that that data is protected.
So, and just to clarify, because this is one of the questions that came in, so your LLMs work on a subset of general data and have access to internal data
Correct.
that you wouldn't put out in the open?
Correct, yes.
Okay. And do you have any advice is there any sort of thinking you can share on sort of how to do that in terms of advice on people that need to make
Well, we
that?
have a whole team that's just dedicated to that, and I'm certainly not an AI expert to comment on that, but it's a great portal. I use it all the time as a user for everything that I do, even when I'm just putting together a sentence in email, and like, it doesn't sound good, let me see if I can get it to AI to help me word it a little bit better, and it does help a lot. And I know that just having I'm also, in addition to the AI Risk, Privacy, and Governance Committee, also on a data use committee, and with senior level people that are also looking at whether our data can or should be used by third parties, you know, because there are some arrangements, research specifically, that we would want to share data. So there are certain instances where we do, but
So you have teams that manage sort of what data is in what category?
Correct.
Fair.
Correct. Yep.
So Jason, I want to bring you back into the conversation. So the tech's really good. Patients have access to some of their data. How do we make it possible for patients to be involved in the decision process around that?
So I think they are. I think, well, there's different types of patients. Some want the practitioner, the provider to make all the decisions and don't want any part of it because they just don't want to be part of it.
Yeah, exactly.
Some want me to do everything. Many of them, though, consider themselves the owners of their data and want to be very involved in the decision-making process, or want a first-degree relative to be. And often, that first-degree relative doesn't have access to all of that data.
Right.
So you wind up not only having an office visit in person, but telehealth, and that gets into other issues, especially with AI as well. So there's, I guess, different relationship models that exist and that evolve over time.
Sure. So Kathy, this is kind of the last point we'll make. HIPAA is just only 30 years old. I reminded myself in my notes to see if anybody in the room is anybody younger than HIPAA? Is anyone younger than, I think we're close. Yeah, there we go. I knew we'd have a couple. So this year, the new DOH cybersecurity rules for hospitals. For people in the audience, could you give us a thumbnail of it for might not be interesting?
Sure, it's a brand new regulation that went into effect actually last October 2024, and at the time, our governor, Kathy Hochul, we're the first state in the country to enact this type of regulation at the state level. And basically what the regulation says is that you have to make sure you're following cybersecurity best practices at hospitals. I mean, that's in essence what it's about. Last year, what went into effect immediately was a 72-hour reporting requirement if there's any type of significant cyber event, because a cyber event at a hospital can cause patient safety and affect patient care. So very, very important. This past October, the rest of the regulation went into effect. And what's different from HIPAA is the fact that it not only requires you to enable or have in place protections for protected health information or PHI, but also requires you to have very similar type of protections in place for what they call non-public information, which is what a hospital would consider, very confidential information. So anything that might affect a hospital from operating, we're also required to report that to the Department of Health if there's a cyber incident.
So Andy, when you had to think about all non-public information versus just PHI, like how do you approach that?
To be perfectly honest, other than public information, I treat everything as PHI.
So like if you wouldn't put it on the internet,
No, it's one of those things that, everybody has data classification, whether it's public, sensitive, really sensitive, and then the 42, like rehab and genetic, which is, and psychology nodes, psychiatric nodes, which are like HIPAA on steroids, super sensitive, but as long as you're treating everything, HIPAA, if you look at the 18 identifiers in HIPAA, it's literally everything. It's your picture, it's your name, it's your address, it's your IP, it's your driver's license, your credit card number. It could be literally anything. So I try and treat everything as sensitive unless it's strictly public. We try and put the same type of controls around the rest of the information. If it's all sensitive, we can put the controls, and it makes the control environment a lot easier.
Yeah. So Keith, how did you make the mental switch with your team to sort of think about all non-public information? What kind of advice do you have for people in the audience around how you handle that?
I think you made a great point about, potentially reaching that decision point where you just treat all information at the highest level. We did a lot of discovery across the environment, and really inventorying the information, and came to a conclusion that, well, it seems like 80% is this, so why should we leave the other 20% out? Because it's important too, and frankly, do we need to differentiate between those two? Let's just make our lives a little bit easier and treat it all the same. So I think, that's kind of how we've tried to approach it, and I think that's the easier part of the mentality switch is let's just protect all the information.
Mm-hmm.
It's that, I think earlier in the conversation, there's the getting people in the mindset of IT as part of the hospital system,
Mm-hmm.
and we're supporting clinicians who are, saving lives and treating people in the best parts of their day, the worst parts of their day as well. That's been, I think, a challenge for all healthcare cybersecurity, is really kind of aligning ourselves in that thought process.
Yeah.
And when you look and you inventory the data, you start to see, well, this is important, this is important, and this is important. You start to make your own connections to it, and I think that's been helpful for my team, to really see that, this could be their data too, and
Yeah.
it is their data as well.
So that's an interesting point, Jason, to bring you in. So you're dealing with the patients. How has your role changed as more and more tech becomes available, and medical grade tech is sort of all like my phone is medical grade tech from even last year maybe, right?
So certainly the hassle factor has increased because it's a hassle to try to integrate all of this. And then you distinguish between data that's medically grade and non-medically grade. And I have to tell you, the margins have blurred. I mean, there's some non-medically grade commercial devices that provide pretty good quality, very high quality data. So I think it's a matter of also stepping back and not being so rigid. And lastly, I find that when there's innovation, there's less integration.
Yeah.
And when you focus on the integration piece, there's risk and there's opportunity. And the more and more that I interact with IT folks and CISOs, the more I have an appreciation of their concerns. And I talked about the geographic distance. In our institution, a meeting is important if it's in person. If it's virtual, maybe not so much.
Get that, people in New York?
But nonetheless, I think those are the three ways that
That's kind of a great point to sort of summarize that. So Keith, your final thoughts for the audience, go.
I think it sounds like we're heading forward an integration revolution, where there's an expectation from our customers to bring it all together, to break down the barriers. So this was incredibly insightful for me to hear that's where I think we're going to be faced with some of our challenges.
Andy, final thoughts?
I kind of agree with Keith. I had worked in private for 30 years before coming to a hospital. My boss
You
has
started in junior
Yeah.
high, I guess.
Yeah, I wish. No, but I mean, my boss has always been an IT person. They're hardcore IT. My boss now is a clinician, so I've got it firsthand, and I'm seeing that integration between IT and the clinical side, and it gives me a much deeper appreciation of what they have to go through, and it gives them a good appreciation of the balancing act that we have to do in protecting but serving at the same time.
Yeah. Kathy, in your last year as a CISO for a large hospital, what's your piece of advice to share?
Yeah, so I think there's a lot going on. There's a lot going on in the world today, especially with AI, and it's going to revolutionize everything that we do. And that's really important, and we always have to have an eye to the future, but we can't lose sight of what's in front of us, right? And what risks we're facing today as we plan for addressing the risks of tomorrow. And the most important thing is really making sure, I always say to people, they say, what's the best advice you can give anybody? Patch, 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 right? We've heard that before. And the second thing is making sure your education and awareness, because it's the person behind the keyboard that's your last line of defense, and them clicking on a link or entering information or doing something, that perhaps got through your security, defense in depth layers that you have is what you're most vulnerable to. So just don't lose sight of the simple things. AI is great and wonderful, and it comes with tremendous benefits, but also tremendous risks that ultimately have to be balanced.
Yeah, we'll leave it right there. Thank you very much. Thank you all very much for your time. Oh yeah, sorry.